Well, good afternoon, everybody, and welcome to the Hassenfeld Institute Seminar Gestational Diabetes Testing, an opportunity to improve population health, presented by Dr. Erika Werner. I'm Amy Anthony. I'm the Communications and Outreach Manager for the Hassenfeld Institute, and I'm pleased to introduce today Dr. Patrick Vivier. Dr. Vivier is the director of the Hassenfeld Child Health Innovation Institute. He is also a professor of emergency medicine and pediatrics in the Warren Alpert Medical School, and he is a professor of health services, policy, and practice in the Brown School of Public Health. So Patrick, I will turn it over to you now.
Terrific. Thank you much, Amy, and thank you for arranging this. Welcome, everybody. Thrilled today to have Dr. Erika Werner giving this talk. Dr. Werner is the director of the Division of Maternal-Fetal Medicine at Women and Infants Hospital and the Warren Alpert Medical School at Brown University, where she's also an associate professor of obstetrics and gynecology. Dr. Werner is also associate professor of epidemiology at the Brown University School of Public Health. She has funding from both the American Diabetes Association and the National Institute of Health to study gestational diabetes and diabetes prevention. She's also on the board of the Society of Maternal-Fetal Medicine and an editor for several journals. She's a member of the Hassenfeld Institute's Executive Committee and a principal investigator in its birth cohort. She also helps lead the Institute's Healthy Weight, Nutrition, and Fitness Initiative. So thank you very much, Dr. Werner. We're excited to hear your talk.
Thank you. I already did the first thing right, which was remembering to take myself off of mute, so I'm feeling pretty good. Thank you for that very kind introduction. I'm excited to share some of our work today, and hoping that we checked beforehand, but there we go. All right, so I have no relevant conflicts, but I do have great appreciation for the Hassenfeld Child Health Innovations Institute, and I'll share some of why I feel so thankful that this institute exists at the end of my talk. So by the end of our roughly 45 minutes together, I promise I'll let you out a little bit early, we will have described gestational diabetes, its associated morbidities, and its cost implications. We'll review how diagnosing gestational diabetes could lead to diabetes prevention, and then evaluate gaps in real-world care to actually achieving this diabetes prevention. I'll present some possible pragmatic solutions to these gaps, and then we'll talk about next steps and the Hassenfeld opportunity. So for those of you that aren't clinicians and don't live and breathe obstetrics like a few on this Zoom, gestational diabetes mellitus, or GDM, is very simply carbohydrate intolerance that begins or is first recognized during pregnancy. Now, I will say there's a little bit of discord. That's the American College of Obstetricians and Gynecologists definition. The American Diabetes Association just defines GDM as diabetes diagnosed during pregnancy that is not clearly overt diabetes. But regardless of how you define it, luckily the care is very similar. So a little bit of a clinical primer. Gestational diabetes is diagnosed in pregnancy, and it's diagnosed all across the United States with universal screening between 24 and 28 weeks of pregnancy. So really nearly all 4 million women that get pregnant each year in the US drink a very yucky drink between 24 and 28 weeks, and then have their sugar drawn 1 hour after that drink. And if their sugar is above a certain level, between 130 and 140 milligrams per deciliter, depending on the hospital, then they screen positive for gestational diabetes. And they're then referred for a diagnostic test, which is a 3-hour glucose tolerance test. So we bring individuals into our labs, we check their sugar, and then we give them an even bigger yucky drink. And then they sit there for 3 hours, and we check their sugar at 1 hour, 2 hours, and 3 hours. This is one of the few tests in pregnancy that women remember years after their pregnancy is over. But that's how we do it in the United States for now. And we've looked at some alternatives, but for right now, this is still the best way to diagnose gestational diabetes. Then for individuals that are diagnosed with gestational diabetes, which is about 6 to 8% of the population, we ask them to check their blood sugars with a finger stick every morning when they wake up, and 1 or 2 hours after every meal during their day, from the time that they're diagnosed with gestational diabetes until the time they deliver. So for about 3 months of their pregnancy usually. We also have them meet with a nutritionist and get started on a diabetic diet. And if that doesn't drive their sugars down into a normal range, then we typically prescribe insulin. Some places will use metformin or glyburide, and about across the country, between 25 and 50% of individuals end up needing medication. Diet just isn't enough. So that's sort of the basics of GDM in pregnancy. So why do we do all this? You can imagine for a pregnant individual, it's a lot of work. Well, it's because there's really good randomized controlled trials that show that diagnosing and treating gestational diabetes improve outcomes. So for the mom, diagnosing and treating gestational diabetes decreases the risk of preeclampsia, which is associated with a lot of maternal morbidity and mortality. It decreases the risk of several infections, and it decreases the risk of cesarean delivery, another driver of morbidity and mortality. Let's see, why are those? Sorry, those boxes are supposed to be filled with things, but you can't see them. For the fetus, it also decreases the risk of being large at birth, which is associated with birth injury, and being born early. And then for the neonate, which is supposed to be in that last box, it decreases the risk of NICU admission, having high bilirubin at delivery, and having low sugars at delivery. So now what do we do with individuals with gestational diabetes after they deliver? Well, this also is very prescribed, much in the same way that the care during pregnancy is. All individuals with gestational diabetes postpartum should be tested for prediabetes or type 2 diabetes. And this is the American College of Obstetricians and Gynecologists algorithm that I'm showing on this slide. And about between 0.5 and 5% of individuals, if tested postpartum, will already have type 2 diabetes. So for some women, either they developed it during pregnancy or they had it before pregnancy and we just didn't know. But for many more women, about 15 to 40%, and in Rhode Island, about 25 to 40% of women who have gestational diabetes will have developed pre-diabetes. And for those women, there are some treatments that we can offer that will reduce the risk of developing type 2 diabetes, and we'll talk more about that in a minute. So why is it important? I explained to you why it's important to intervene during pregnancy. Why is it important to do this test postpartum and intervene? And that's because gestational diabetes really does provide us a window into an individual's future. So about 70% of individuals who have gestational diabetes in pregnancy will develop type 2 diabetes over their life course. But what's really important is that middle group in that sort of flow sheet that I showed you, individuals who have pre-diabetes and a history of gestational diabetes. Their risk of developing type 2 diabetes isn't just over their lifetime, it's really in the subsequent decade. So this is data from the Diabetes Prevention Program, and what you see here are that individuals who have both gestational diabetes and pre-diabetes have almost a 70% chance of developing type 2 diabetes over the subsequent decade. So this is a group that if we diagnose them after pregnancy with pre-diabetes, they have a real risk of getting type 2 diabetes in the near term. But what's unique about individuals with a history of gestational diabetes is that if we either do lifestyle modification as prescribed in the Diabetes Prevention Program or start them on metformin when they have prediabetes, we can make a significant reduction in their type 2 diabetes risk. So between 35 and 40% risk over 10 years. It's about 50% risk reduction at 3 years, and then 35 to 40% over 10, and that persists actually out to 15 years. So if we successfully can identify the women who have a history of GDM and then have prediabetes soon after delivery, we could make an enormous impact on society. So this is just to give you some simple math. I mentioned earlier that 4 million women who get pregnant each year in the United States. About 320,000 of them will be diagnosed with gestational diabetes. And if we tested all of those individuals postpartum, as we're supposed to, about 80,000 of them would have prediabetes after they deliver. And if we then started lifestyle modification or metformin, we could drive down the number of cases of type 2 diabetes in individuals with gestational diabetes by about 20,000 per year or more. But it isn't just about individual health. So this is a little bit of a curve, but Patrick knows this about me. One of my sort of early research loves was cost effectiveness, and it's sort of what got me launched into research. So I wanted to tell you a little bit about the costs of diabetes and gestational diabetes care. So we're going to take a brief swerve into cost effectiveness and the cost ramifications of gestational diabetes care. So if we think about the costs associated with gestational diabetes, we have to pay for both the screening test that I mentioned and the diagnostic test for a smaller population of people. Then we have to do all that gestational diabetes management that I talked about. So the nutritional counseling, the insulin if needed. And then after delivery, if somebody has prediabetes, we have to get them the lifestyle modification that the diabetes prevention program recommended, or start them on metformin. But we do all of that to lead to better health. So if we do all of those things, we reduce the risk of preeclampsia, cesarean delivery, birth injury, and diabetes. And I just included 4 of the bigger cost items on the effect side. All right, so when I was a fellow long ago, I wondered, so with all of those costs, is it really worth the effect that we had? This was published in Diabetes Care at this point almost a decade ago, but led me into all of this line of research that we're going to go over today. And so we did a cost effectiveness study. And for any of you who have done a cost effectiveness study, you probably know that the primary outcome for any cost effectiveness study is typically the incremental cost effectiveness ratio. But for those of you that haven't read a lot of these papers, that's very simply just the difference in cost divided by the difference in effect for a particular strategy. So in this case, the difference in cost between gestational diabetes screening versus not screening divided by the difference in effect between gestational diabetes screening or not screening on a population level. Then you take that incremental cost effectiveness ratio and you have to figure out if it's cost effective or not, if a strategy is cost effective. And that very simply is based on society's willingness to pay. So if the incremental cost effectiveness ratio, the difference in cost divided by the difference in effect, is less than society's willingness to pay, then a strategy is cost effective. If it's more than a society's willingness to pay, then it's not cost effective. And for most of clinical medicine, we long ago decided as a society that we were willing to pay for dialysis. And dialysis costs, not charges, but costs society about $50,000 to $100,000 a year for each patient, and gets patients a pretty normal quality of life, other than a lot of extra doctor's visits. So for clinical medicine, most clinical strategies are cost effective if they cost less than $100,000 for a perfect quality adjusted life year. And they're not cost effective if they cost more than $100,000 for a perfect quality adjusted life year. All right, so keep that in mind as we turn our attention back to gestational diabetes. So this is what a typical decision model looks like. And you start with the decision, in this case, to screen or not to screen for gestational diabetes. Then the consequences of that decision. So in this case, pregnancy complications, if you screen or don't screen, maternal and neonatal outcomes, if you screen or don't screen, and then unintended consequences like false positives. So people that you diagnose with gestational diabetes that don't actually have it, but incur all the costs, but don't really get any benefit. Then you go to the literature, you come up with the probability of those consequences, the costs of the decisions, the costs of the consequences, and the effects. And for obstetrical studies, the effect includes both the effects on the mom and the effects on the child. All right, so you put all that in. And so for gestational diabetes, if we take a population of 100,000 people and we decide to screen them compared to not screen them for gestational diabetes, then that leads to treatment and risk reduction. And so by testing for gestational diabetes, we prevent 56 shoulder dystocias annually in a population of 100,000 individuals, 220 cases of preeclampsia, 446 cases of type 2 diabetes. And when you plug all that in, you end up improving quality adjusted life years by over 2,000, but at a huge cost, at $38 million. But when you take that cost and divide it by the effect, you're left with an incremental cost effectiveness ratio of $16,000 or a little bit more. And as I said, that's below the $100,000 mark. So gestational diabetes is gestational diabetes screening from a societal perspective is cost effective. Makes sense. It's what we do in clinical care all the time, right? Okay, well that we affirmed that what we are doing on a public health level makes sense. Well, that's not quite the whole story. So all models have assumptions. And when building this GDM model, we assumed that diagnosing and treating gestational diabetes would lead to better maternal outcomes, which it does, that it would improve neonatal outcomes, which it does. And we don't have time today to go through all the data, but there's large cohort studies that prove this, as well as randomized controlled trials. But what's more fuzzy in the literature is, does diagnosing gestational diabetes actually lead to type 2 diabetes prevention. And so if we take that assumption out of the model, then we remove the $9,000 per person cost for the diabetes prevention program, but we don't reduce the number of type 2 diabetes cases prevented. And so when we rerun the model with the new assumptions, what we get is that you only improve quality adjusted life years by 17. You still prevent the preeclampsia, you still prevent the birth injury, and it costs a lot less. It only costs about $9 million. But again, cost divided by effect, that gives you an ICER of over $500,000 a year, which is not cost effective from a societal perspective. So our takeaway from this study was that in order for us to continue doing gestational diabetes testing across the US as we currently do, we really need to take what we learn in pregnancy and use it to prevent type 2 diabetes. The diabetes prevention program already gave us a roadmap to do that. And to not do it actually makes this pregnancy screening test that every pregnant woman gets not cost effective from a societal perspective. So in the same way that we wouldn't do a stress test and ignore the results, because then there's no point in doing it, we shouldn't do a gestational diabetes screening test and then ignore the results after a woman delivers. So we need to figure out how to effectively intervene postpartum. All right, so as I said, the diabetes prevention program gave us a great roadmap for how to do that. You diagnose gestational diabetes, then you intervene postpartum and identify those individuals with prediabetes. Then you either offer those women metformin or lifestyle modification, and that leads to diabetes prevention. That all sounds great, right? But that's not really how clinical medicine works. So what are we doing well? Well, if you look at the ability to test women during pregnancy, we actually do a really great job. More than 95% of individuals that become pregnant get tested for gestational diabetes. So we actually do that first step really, really well. How do we do with the postpartum glucose tolerance test? How do we do with that 4 to 12 week test that every woman's supposed to be doing? ACOG recommended this more than 20 years ago. How are we doing with that? Well, this is older data, but it hasn't gotten better. South Carolina is sort of sets the bar a little low. 3% of individuals in South Carolina get a postpartum glucose tolerance test by 13 weeks postpartum. In a study that I helped with in Maryland, 6% of publicly insured individuals and 11% of privately insured individuals get any glucose testing after a diagnosis of gestational diabetes by 12 weeks postpartum. Now in Massachusetts, they hypothesized that maybe people were just getting it done later in their postpartum course. So they went out as far as a year and a half and found that only 37% of individuals with gestational diabetes get tested in the year and a half following their diagnosis. Quest looked at their data. Similarly, individuals with gestational diabetes were not getting tested postpartum with even a fasting plasma glucose, no glucose checks after delivery. Now, Kaiser is the one outlier. They've really focused on this. And they now, this is older data, but they now get almost 60% of individuals with gestational diabetes to come back postpartum for a glucose tolerance test. But they incentivize their providers, they incentivize patients, they go over and above, and they still are only getting 50 to 60% of individuals to come back. So clearly we have some barriers to postpartum testing. So what are those barriers? We've done a lot of work in this area, both in Maryland and now in Rhode Island. And I won't spend a lot of time going into all the ins and outs of the data we've collected. But in short, in terms of less modifiable risk factors, insurance, education, type of gestational diabetes, and having a history of gestational diabetes are pretty significantly associated with whether individuals will return for a postpartum glucose tolerance test. Surprisingly, things that predict adherence in other settings in obstetrics are not as significant. So age, race, how complicated your delivery is, family history, don't seem to be predictors of whether an individual comes back for postpartum glucose tolerance testing or not. We'll talk a little bit more about race ethnicity on a future slide, but in short, the Latina community actually there's is sort of a focus. They've done studies in California and Texas. Is very aware of the risk of type 2 diabetes, and therefore actually in some studies has been shown to be more likely to come back for postpartum glucose testing. Not quite what we found in Rhode Island, but certainly not less likely to come back. One of the other things that's interesting is that individuals who have a history of gestational diabetes in a prior pregnancy are actually less likely to come back and get tested for type 2 diabetes, which is particularly concerning because it means they test positive in multiple pregnancies, but still don't get tested for prediabetes or type 2 diabetes after they deliver. But what about more modifiable barriers to postpartum testing? Before we did a 300-person sort of survey study using validated tools, I really hypothesized that going back to work early or attending work or school would be a barrier to individuals coming back to get their postpartum glucose tolerance test. I also thought that childcare, not having childcare, would be a big barrier. But neither of those turned out to be a barrier to women coming back to get postpartum glucose testing. Reliable transportation, trust in your physician, and your own health attitude, whether you thought you were in control of your ability to prevent disease, were sort of three of the things that came back as most significant for being associated with whether individuals returned for their glucose tolerance test or did not return. And we used validated surveys for all of these factors. All right, so if we think about these factors, insurance, education, transportation, trust in your provider, and prevention awareness, it makes sense that the changes that have been attempted to get women to come postpartum for a glucose tolerance test, changing the test to hemoglobin A1C, which instead of a 2-hour glucose tolerance test where you have to sit still for 2 hours, that might help with transportation, but it doesn't really address the other issues. Incentives, maybe the incentives help the insurance because maybe you can pay for the test with your incentive, but they don't address a lot of the other issues. And additional support staff, maybe that helps with trust in the provider, but it's not going to fix the transportation issues. So none of these changes have really gotten 90% or more of individuals to come back for postpartum glucose testing. So as we were doing all of this work, we wondered, how do we fix all of these barriers? And in particular, could we do the 2-hour glucose tolerance test in the hospital after delivery? And so for any of you who are still in the trainee phase of your careers, this was a real learning point for me. When I sort of first had that epiphany, why don't we do this during the hospital stay? I assumed that the reason we didn't was evidence-based, that somebody much smarter than me had already done that and figured it out, and we couldn't do it then, it was too soon. But it turned out that wasn't the case. And if we look at the hormones associated with gestational diabetes, human placental lactogen, progesterone, placental growth hormone, CRH, and leptin, they all go back to near normal levels, not within weeks after delivery, but within hours to days after delivery. So there wasn't a biologic reason that we couldn't do it sooner. And there wasn't actually any other studies that had looked at whether we could do it sooner, which was sort of shocking to me. So I went to the experts and I said, 30 years ago, why did you pick 6 to 12 weeks or now 4 to 12 weeks postpartum for the postpartum glucose test? And Don Kustin, who's amazing, who worked with me at the time here, was one of the creators of gestational diabetes and did a lot of the formative research. And he said we were trying to make it easier for patients. We knew they would be coming back for their postpartum visit, and we were trying to be pragmatic. When you come back for your postpartum visit, you can have this test too. And I think that's, makes a lot of sense in the abstract, but fast forward, a generation and it's not working. And so how do we fix that? And so we wanted to do exactly that. So we decided that we should try doing the glucose test inpatient. It wasn't working outpatient, so could we move it to inpatient? And in particular, we sort of thought through, would this address the barriers? And women or individuals who have kids, they have insurance, even if it's emergency insurance when they're in the hospital. So it removes the insurance barrier. They don't have to go anywhere. They're already in the hospital, so it removes the transportation barrier. There's a lot of downtime postpartum in the hospital where you have time to educate individuals on why this test is important and to discuss how much control they have over preventing the development of type 2 diabetes. I think the one barrier that I don't know if moving it inpatient addresses is trust in your provider. But there is some data to suggest that you have the most trust, or the most rapport at least, with the provider that delivers you. And so maybe having that provider explain the importance of this test may also improve that barrier. So luckily, at the same time that we had this idea, several other investigators across the country had the same idea. And right around the same time, 4 of us all published pilot studies that compared the 1 to 4 day postpartum glucose tolerance test to the 4 to 12 week postpartum glucose tolerance test, which is the current gold standard. And we all published our results, and then with help from the CDC, we all pooled our results, because these were all pilot studies with numbers of between 30 and 60 participants in each study. And when we pooled our data, what was really interesting was that all of us had more than 90% adherence to the 1 to 4 day postpartum test. And all of us had less than 50% adherence to the 4 to 12 week test, even though we incentivized women, even though we went above and beyond to try to make it as easy as possible to get that test done. Then this is sort of the summary of all of our results pooled together. And you can see the sensitivity and specificity is not ideal for identifying diabetes or impaired glucose metabolism. But what kind of stuck with us all was the negative predictive value. So individuals that have a 2-day postpartum glucose tolerance test that's normal have a very low risk of having diabetes at 4 to 12 weeks, and also have a fairly low risk of having impaired glucose metabolism at 4 to 12 weeks. So that was great, but still a small sample size, no long-term data, didn't seem like enough to actually change practice. So what do we do next? Well, I and my colleagues felt that a larger, longer study was needed. And so luckily, the American Diabetes Association agreed. And so this was published, I believe it was published in print a few months ago, online about a year ago. And so I'm going to spend a little time going through this study. And really the main point of this study was to compare the 2-day postpartum glucose tolerance test to the 4 to 12 week postpartum glucose tolerance test against more of a gold standard, 1 year glucose metabolism results, 1 year postpartum glucose metabolism results. So both to detect impaired glucose metabolism and type 2 diabetes. So this was a prospective cohort study. We started recruiting in January of 2017 through June of 2018. We recruited 300 women. And the inclusion criteria were intended to be quite broad. We wanted individuals that had C-sections, vaginal deliveries, preterm, term, from all different backgrounds, fluent in English or Spanish, diagnosed with gestational diabetes by the typical way that it's diagnosed across the country, the Carpenter-Kusten criteria. And we excluded individuals if they were going to leave the hospital on postpartum day 1, because the test was being done on postpartum day 2, or if they were intending to move out of state in the subsequent year. Or for a small group of individuals who've had gastric bypass, they sometimes can't tolerate the glucose tolerance test, and so we excluded them as well. We recruited individuals on the postpartum floors at Women and Infants on postpartum day 1. On postpartum day 2, they underwent this yucky 2-hour 75-gram glucose tolerance test. But we didn't share the results with the participants or the providers unless the results were above 250 milligrams per deciliter, just as a safety, for safety reasons, because we didn't want them to change their behaviors between postpartum day 2 and 4 to 12 weeks. We'll give you a little hint on the results, and that none of the individuals actually ended up having glucose values above 250, so we didn't have to unblind anybody. And then we again invited individuals back at 4 to 12 weeks postpartum, and we gave patients multiple reminder phone calls. They got 3 calls from the research assistants, and then the final call was from me asking them to please come in, explaining the importance of the 4 to 12 week test. We incentivized individuals $50 for coming back to have this clinically indicated test that they needed to have anyway. And we provided free transportation if that was an issue. Our primary outcome was glycosylated hemoglobin at 1 year postpartum. Hemoglobin A1C greater than or equal to 5.7 is consistent with impaired glucose metabolism, and greater than or equal to 6.5 is consistent with type 2 diabetes. So that was our primary outcome. So let's see, there we go. The primary aim, as I said, was to compare the 2-day postpartum GTT to the 4 to 12-week postpartum GTT to detect abnormal glucose metabolism at 1 year postpartum. So anybody with a hemoglobin A1C of 5.7% or higher. And we powered the study to detect a 0.2 difference in the ROC curves. But I think particularly when I give this talk to clinicians, we did power it assuming that we would lose 50% to follow-up. And I think for, any researchers, that is sort of gives them pause, as it should. But that was sort of the only way to do this study in a realistic fashion. So, all right, so moving on to the results. So we recruited 300 individuals, 296 of them, or 99%, completed the postpartum day 2 glucose tolerance test. So I considered that a victory, but we didn't stop there. Then we were able to get 202 of them to come back for the 4 to 12 week glucose tolerance test. One of those individuals who came back was somebody who wasn't able to complete the postpartum day 2 test. And I should mention the 4 women that weren't able to complete the postpartum day 2 test, 2 of them left the hospital early, even though we tried to not recruit individuals that were leaving early, but they decided to leave early unexpectedly. And 2 individuals were fairly sick on postpartum day 2, and we decided, because it was a research study, to not give them the test. One was in the ICU and one had a very fast heartbeat that was being worked up, and we didn't want a glucose load to affect that. But in practice, you could then give it at postpartum day 3 or day 4 if you needed to. So then of the individuals that came both for the postpartum day 2 glucose tolerance test and for the 4 to 12 week glucose tolerance test, 168 of them returned at 1 year for a hemoglobin A1C, and then an additional 35 women also came back for a hemoglobin A1C at 1 year who had missed one of these 2 tests. The majority of them, 33 of them, had missed that 4 to 12 week test. But I found that interesting in and of itself, that individuals were willing to come back at 1 year who weren't willing to come back at 4 to 12 weeks, and sort of played, at least in my head, to the narrative that 4 to 12 weeks is really not an ideal time for individuals to return to sit still for a 2-hour test. All right, so what I'm showing here is the baseline demographics, both of our whole cohort, but then also of the individuals that returned at 1 year, because we did have a significant loss to follow-up rate that we anticipated. But what I will tell you is that I didn't include p-values here, but there was not a significant difference between the individuals that returned at 1 year or the individuals that returned at 4 to 12 weeks compared to the whole cohort. While there wasn't just a statistically significant difference in any of these variables, what I will draw your attention to is the race ethnicity. As I said, there are some studies to suggest that some minority populations are actually more likely to come back than their Caucasian counterparts to postpartum testing. And while it wasn't statistically significant in our cohort, you will see that 54% of our recruited population was Caucasian. But I think it was 49% of the individuals that returned at 4 to 12 weeks were Caucasian, and 48% that returned at 1 year were Caucasian. You'll also notice that it is a fairly overweight cohort, and that's because obesity is directly correlated with the rates of gestational diabetes. All right, so glucose test results by time. Regardless of which time point we look at, 4% of our cohort had type 2 diabetes at each time point. And in terms of impaired glucose metabolism, at 2 days postpartum, 29% had impaired glucose metabolism. At 4 to 12 weeks, it was 25%, and at 1 year, it was 35%. So I think, really showing that many women after delivery continue to have abnormal glucose metabolism. All right, so now to the meat of this. When we look at the 2-day postpartum glucose tolerance test compared to the 4 to 12 week postpartum glucose tolerance test, with a goal of identifying impaired glucose metabolism at 1 year postpartum, there is no significant difference in the sensitivity, specificity, positive predictive value, or negative predictive value. And I think this is easier to see on the ROC curves. So you see that the 2-day area under the curve is 0.59 and the 4 to 12 week area under the curve is 0.58. So not different at all. Now we could spend a whole nother hour talking about the areas under the curve and whether that's really an ideal screening test or diagnostic test, which I think you could make an argument that is definitely not. But the bottom line is, if our current standard of care is the 4 to 12 week glucose tolerance test, the 2-day test is definitely no worse. All right, how about identifying diabetes at 1 year? So when we compare the 2-day postpartum glucose tolerance test to the 4 to 12 week postpartum glucose tolerance test, with a goal of identifying those individuals with diabetes, again, no difference in sensitivity, no difference in specificity, no difference in positive predictive value, and no difference in negative predictive value. And I will draw your attention, the negative predictive value is superb, but the positive predictive value is pretty lousy. And we'll talk about that in a little bit. So again, easier to see with the ROC curves, but the area under the curve for identifying individuals with type 2 diabetes was not significantly different between the 2-day postpartum GTT and the 4 to 12 week postpartum GTT. So to sort of just give a summary of this study, again, the adherence to the 2-day test was 99%. That is way better than anybody has done, even Kaiser, on the 4 to 12 week postpartum GTT. The 2-day postpartum glucose tolerance test had a similar diagnostic value as the 4 to 12 week glucose tolerance test in identifying impaired glucose metabolism and type 2 diabetes, for that matter, at 1 year postpartum. And both the 2-day GTT and the 4 to 12 week GTT have a high negative predictive value, but a low positive predictive value for diabetes and impaired glucose metabolism at 1 year. So where does this take us? This study only had 1 year follow-up, and in an ideal world, we would have followed these individuals for 5 or 10 years till they, till most of them progressed to type 2 diabetes. But so far, nobody's been willing to fund us indefinitely. So 1 year was all we could do. This is a single-centered study. I will mention that Women and Infants delivers 80% of Rhode Island, so I think this study is very much generalizable to all of Rhode Island. But is it generalizable to other states? I think we did have a very diverse cohort, both in terms of socioeconomic, in terms of comorbidities, in terms of race, ethnicity, in terms of age. So I think this study is fairly generalizable, but it would be nice to see other studies across the country do similar work. And then I think the real limitation of this is the 4 to 12 week test as a comparison point. Neither test is ideal. So are there additional pregnancy variables that could be added to better predict disease at 1 year? And are there other metabolic measures during pregnancy, even before individuals deliver, that might better predict prediabetes and diabetes? Do we need to test women at all postpartum? Could we do this all using better prediction during pregnancy? And then we'd have the entire pregnancy to educate individuals on their risk of diabetes. So those are the questions that we're really focusing on going forward. So with Anna Dice and Dr. Angie Benston, who is on maternity leave right now, I've been lucky enough through the Hassenfeld Institute to get to know them a little bit, and they have built a fabulous model using some of our data to better predict prediabetes at 1 year postpartum using more complicated methodological approaches than I could have ever come up with on my own. And they're actually presenting that this year at a conference, and hopefully we'll publish it soon after that. So I'm not presenting any of those results at this time, but really interesting with much better positive predictive value if we include some of the clinical predictors of prediabetes and diabetes. Thanks in large part to the Hassenfeld Institute, we also were awarded a U01 with 6 other centers across the US to try to get at better ways during pregnancy to identify glycemic patterns that are most associated with prediabetes and type 2 diabetes. We're waiting on IRB approval and hoping that study will start maybe next month. And then I think the next place that this takes us is what do we do when women are diagnosed with prediabetes postpartum? How do we we really take advantage of the diabetes prevention program? Should we be offering those solutions to everybody with gestational diabetes? Should we be offering them just to people with impaired fasting glucose, or just to individuals with impaired glucose tolerance? I didn't have time to get into all of those nuances today, but I think it sort of leads us to a randomized control trial that we are beginning to formulate and put together and hoping to submit soon to the NIH. So now I do want to just take a minute to talk about how all of this work, a lot of this work predated the Hassenfeld Innovations Institute, but certainly all of our next steps are very much going to be done with all the resources that are available through the Hassenfeld Child Health Innovations Institute, and with appreciation. So this is the staff pre-COVID. We've not been able to have a picture since COVID started, but of the Hassenfeld research team, research nurses, research assistants, data analysts, you'll see Patrick and me there, really a wonderful team that is in the hospital and all across the state, helping to build this infrastructure. So what is the Hassenfeld Child Health Innovations Institute, and why is it going to make my work so much easier going forward? First of all, I mentioned how I've been able to connect more with experts over at the School of Public Health. The Hassenfeld Child Health Innovations Institute is a convener of researchers interested in maternal child health at Women and Infants, at Lifespan, all across Care New England and Lifespan, and at Brown. And that brings us lectures like this, which I've attended some as a listener and have really enjoyed. It also provides infrastructure for prospective research, like many of the next steps that I just described. We have a bilingual research team who recruits in prenatal clinics across Rhode Island and on the postpartum floors at Women and Infants. We have a dedicated IRB coordinator who we just hired a couple months ago that makes putting in IRBs at Brown, Women and Infants, and even Lifespan much easier. We have a dedicated specimens collection team that knows how to get placenta and cord blood and handle all of those specimens really well. And we have an amazing data analytics team that has expertise in maternal child health outcomes research and geocoding. And they sit over in the School of Public Health. It also, the Hassenfeld Child Health Institute, I mentioned the UO1 that we got, it also makes grant writing much, much easier. We have boilerplate language describing recruitment and retention strategies. And I put up our retention statistics, which got a little bit worse during COVID. Before, we used to be able to say we had one-year follow-up rates above 90%, but still really exceptional compared to other studies that I've been a part of, or that my colleagues across the country have been a part of. So individuals that we recruit prenatally, we have an 89% one-year follow-up rate, an 82% two-year follow-up rate, and a 79% three-year follow-up rate. For individuals that we meet for the first time right after they deliver, we have almost an 80% follow-up rate. So these are individuals that basically we meet when they deliver, and then we ask them to answer a call from us at 1 year. So I think that's pretty impressive. We also have a really diverse cohort and can get you data if you have interest in writing grants or using this cohort about that cohort. So, rates of preeclampsia, rate of gestational diabetes, rates of NICU admission, that sort of thing. And you're able to buy into this network so that if you don't have your own pre-made recruitment and retention infrastructure, then we can help you do that. So with that, I wanted to have 15 minutes left, and I think I timed it pretty well. So I would like to thank both the Maternal-Fetal Medicine unit nurses who helped me with this American Diabetes Association grant. They are amazing, and I think I saw Janet on this call, and she deserves a ton of credit. She basically did everything related to the study that I presented for the middle part of this. And also just thanks to Patrick and Amy for organizing this today, and to everybody at Hassenfeld for helping me with putting this together and all the work we do every day. So I'm happy to take any questions.
Terrific. Thank you so much, Dr. Werner. We will now open it to questions. If people can either raise their hand, or if we stop sharing, we might be able to see people for that. Or people can unmute themselves if they want to ask directly. Do we have a first question?
I'll ask a question. Hi, Erika.
Hello, how are you?
I'm good, thank you. I had a question about how the information about gestational diabetes is shared with the primary care provider postpartum?
That's a great point.
Because it seems to me that in most cases they would be the follow-up.
Yeah, there's actually been a lot of work done in this area, not necessarily solving any of the problems quite yet. So typically it's the OBGYN that sends the postpartum glucose tolerance test. And then ideally, the way it's supposed to work is if the results are normal, they send a note to the primary care provider saying the patient should be tested every 1 to 3 years. If they have prediabetes, then they actually refer the patient to their primary care provider to say the patient has prediabetes, please engage them in lifestyle modification and talk to them about their diabetes risk. And then if they have diabetes, they refer them either to an endocrinologist or if the primary care doctor is comfortable treating their diabetes, that's great too. For our study, we sort of put the onus back. We basically sent those recommendations to the OBGYN doctors, but asked the OBGYN doctors to talk to the patients and get in touch with the primary care doctors. The group up at Brigham has done some work on this and using Epic to basically jointly message OBGYNs every time, to jointly message PCPs whenever they give OBGYNs messages on postpartum glucose information. And that has helped. And I think there's a lot of work being done on the Kaiser side as well of using the electronic medical record to handle this so that PCPs get sort of a pop-up every time they're seeing a patient who had gestational diabetes. But if you switch providers or switch EMRs, it is definitely a problematic step. So one of the things that we started here at Women and Infants after this study concluded that I think a lot of centers are starting is doing joint clinics with primary care. So a small portion of our patients now have postpartum visits with an OBGYN and a primary care doctor to sort of bridge that gap. But that is, it is definitely a problem with the, as we get, and especially as we get more specialized, it's only going to get worse with more gaps in care. I hope I answered your question.
Dr. Werner, actually, I had a question. This might be a naive question from the pediatrician, but did I hear you correctly at the beginning that treating the gestational diabetes lowers the risk of long-term diabetes in the mom?
So not treating the great question. No, I should clarify that. Interestingly, treating gestational diabetes lowers the risk of type 2 diabetes in the offspring, but diagnosing gestational diabetes, if it's followed up with postpartum testing and intervention after delivery, prevents type 2 diabetes in the mom. But just treating the gestational diabetes doesn't have any effect on the long-term risk of diabetes for the mom. You have to intervene postpartum to get that benefit.
Oh, terrific. Okay, that
makes sense.
Yeah, no, it makes sense because I guess I always assumed that the gestational diabetes was sort of a sign that the mother was susceptible to diabetes. So I didn't quite follow how
you have to intervene postpartum to get the type 2 diabetes prevention for the mom, which is, I suppose you do get the education, the sort of nutrition education that women get during pregnancy, theoretically could help reduce their type 2 diabetes risk, but in cohort studies, that never manifests into a signal of type 2 diabetes reduction. That few visits doesn't seem to be enough. You have to intervene postpartum with something like the diabetes prevention program had, which was, I believe, 13 lifestyle modification sessions with a nutritionist, or maybe metformin. I think there's a lot of hope that starting women with gestational diabetes on metformin after they deliver and having them take it for a year may lead to weight reduction that is more sustained, and that weight reduction would reduce your type 2 diabetes risk.
Great. And my other question you just partially answered, in terms of the long-term impact on the baby of identifying and treating gestational diabetes. Could you talk about that just a little bit more?
Yeah, actually, there was a study that just came out last week, I believe, that had longer-term U.S. data, which we've been waiting for. But in European studies, there's consistently been a trend that the diagnosing and treating gestational diabetes reduces childhood obesity, reduces teenage obesity, and that was just confirmed in this US study. And when they look at like adiposity at 5 years of age and adiposity at 18, early signs of hypertension in teenagers, all of that is reduced if you diagnose and treat gestational diabetes. So untreated gestational diabetes, higher risk of obesity in the offspring, higher risk of cardiovascular disease in the offspring versus those that are treated.
Any other questions from our audience? Or I'm going to.
So I will. Maybe I'll just mention we did just roll this out at Women and Infants. So we are now offering. I shouldn't say just, about a month ago, we started offering the 2-day postpartum glucose tolerance test to women after they deliver as part of routine care. It seems like about a third of individuals are choosing to do that, or their providers are offering it to them and they're accepting. What's interesting is that the majority of the resident service is getting this, so I do wonder a little bit about providers. Cornell in New York also started, actually, I think a little bit before us, and then I think 2 hospitals in Ohio have also started. So I think we will start to see more places across the country offering this to individuals who have gestational diabetes, and that's exciting. I hope we're gonna have to follow that data and make sure it actually gets us what we're hoping it will, which is better communication with the PCPs. I mean, I think we're hoping that if individuals leave the hospital knowing whether they have prediabetes or type 2 diabetes, that it will give them more time and providers more time to connect with primary care doctors and sort of fill in that gap.
Well, if there are no other questions, I think we're pretty close to time. I want to thank you so much for an incredibly interesting talk and for this important work that you're doing. It's just wonderful to hear.
I am going to put in one plug for any of you that are interested in talking about Hassenfeld. Patrick and Amy and I are all easy to get in touch with. And if you just go to Hassenfeld, you type in Hassenfeld and Brown, you will get to the website where you can find all of our emails, and eager to talk to anybody that wants to try to use the cohort or the infrastructure to do research.
Terrific.
Absolutely.
Thank you, Dr. Werner. Thank you, Dean Weddle, for your question,
Yes,
and also a member of our advisory council. And thank you to Amy for organizing this.
It's just wonderful to see how the gleam in the eye of Ellen Hassenfeld and Patrick have formed this amazing infrastructure that allows the kind of work you're doing to be done efficiently. I really love it. Yay.
We're very appreciative. Thank you.
Thank you.
Thank you for joining us.
Thank you so much. Thanks, Erika. Thank you, everybody.
Thank you.
Take care. Thank you.
Take care.